Good evening, everyone. Welcome to the webinar of community epidemic prevention in November. My name is Zhang Kaiping, Secretary General of Taiwan Society of Home Health Care. Today, it's okay? Okay.
Yeah, I think maybe you can still use some Chinese.
OK， 好，各位我们线上的观众朋友们，大家晚安。我是台湾在宅医疗学会的秘书长张凯平，也是今晚的主持人。欢迎大家参与我们今天11月的线上防疫论坛。今天呢，我们很荣幸的能够邀请到我们的陈锦煌医师，还有远从美国跟日本的医师来跟我们分享，如何在全球的疫情情况之下，面临我们跟应对我们的高龄化的社会当中，各种的 COVID-19 的病人。怎么样去治疗，怎么样去诊断，怎么样做好社区防疫的工作，会是今天晚上我们国际化的整个的演讲的这个主题。那今天呢，因为我们是一个国际化的演讲，所以我们的讲者还有我们的整个论坛进行的方式，会是以英文的方式来进行，会后也会整理成中文的摘要，给予我们有兴趣的各位观众朋友们分享。So let's start in English. Hello everyone, good evening and good morning in United States. My name is Zhang Kaiping, Secretary General of Taiwan Society of Home Health Care. Today it's our great honor to invite speakers from United States, Japan, and Taiwan to give us experience worldwide about treating and caring COVID-19 patients and how to do the epidemic prevention in the community. So let's now, although there people are caring about the United States presidential elections, but now we can just have a closer look about the pandemic now. Now we got about 50 million confirmed cases worldwide, and only in the United States, I think it's about 10 million, and the global death is about 1 million death tolls. So the confirmed numbers is still on the rise. How do we face this pandemic? How do we treat the patients? And how do we do the community epidemic control and to decrease the epidemic spread? I think this is the focus of tonight. So the first, let's invite our founder of this alliance, Dr. Chen Jin Hong from Xingang, to give us an opening remark. Please welcome Dr. Chen.
Thank you, the chairperson, Dr. Zhang Kaiping, and very glad to see Dr. Pu in US and Dr. Ogulab in Japan, and all of the audience on the webinar. I'm Dr. Chen in Xingang. As a founder of this alliance, it's my honor to have a short talk at the beginning. Next. Maybe due to the American president campaign effect, last week, US just got its worst week ever for the virus. There are about 927 cases in last week. And also in Europe, they every day break a new cases. Next. So in Germany, they implement a new lockdown on November 1. This picture shows a city in Germany. Next one. But the data is yesterday. Today, just a chairperson I talked, we 4 new cases today. So totally, we have about 573 cases. And 7 of them is deaths. Most of cases come from other countries. It's a good data till now because we have do good border control. So as Time magazine on October 29 reported that Taiwan achieved a record 200 days with no local coronavirus cases. The reason is we crossing border early and tightly. Next slide, please. Next slide, please. And second, this one. Second is we do a rigorous contact tracing, technology or endorsed quarantine, universal mask wearing. And five, I think is most important is that Taiwan deadly experience with SARS in 2003 that has scaled the people in Taiwan into compliance. Next slide, please. So since July 8, we lifted the lockdown, the city lockdown, and began normal life. Up to now, in Taiwan, we are facing the dilemma of COVID-19 pandemic control or economic recovery. But people live as if nothing is happening. As I show the picture in the PPT, you can find that in Penghu, in Chiayi, the right low one is in Xingkang. Just last Sunday, we have a marathon running contest. All of the tourist sites full of the people. Next one, please. Next one, please. But we never forget, next one, please. We never forget that COVID-19 is a new emerging infection disease. In Taiwan, only a little more than 500 people have got diagnosed with COVID-19 in 230 million Taiwanese. Most of it come from other countries. This fact means that vast majority of Taiwan people go without immunity. And most important is that nearly all of the primary care physicians like me, lack the experience, like Dr. Yu and Dr. Ogulab, your excellent experience in diagnosis and treatment of COVID-19. Not mention the telemedicine or the home care practice. The reason I think another fact I think is very important. Next one, please. Next one, please. Another, I think very important that in Taiwan, we have inadequate primary care. We lack family physician system and poor doctor-patient relationship. And every day we do more treatment and less prevention. So patients easily go doctor shopping in the community. All our reason increase the risks of spreading COVID-19. So if local transmission really occur in Taiwan, the community will become the hotbed of COVID-19. Next one. So as a, next one, please. Next one, please. So as a local medical doctor in Xingkang community for nearly 40 years, I have some questions. The first one is how to protect yourself and not let your clinic become the super spreader of COVID-19. The question two is how to be a good hospital at-home doctor in tackling this pandemic. How can the government help us? How to empower us now in preparedness? And what is your quick suggestions? And third, what is your experience using telemedicine to care COVID-19 patients? And how many percentage of patients using it? And is there any problems? Next one. So Next one, please. So finally, I use an old saying. Next one, please. An old saying in Chinese military discipline. 中文来说就是说，下一章 ，next one，next one please。我引用《孙子兵法》的一句话来做今天的结束。用兵之法，无事其不然，事无有以待也；无事其不公，事无有所不可攻也。The means is that the national utmost security depends not on whether or not the enemy will attack, but on how much we have prepared ourselves. At this time, I think it's very important to our preparation. So I think tonight, Dr. Ogulab or Dr. Yu in Japan and in America can give us a good and very excellent experience to help us do our preparation. Thank you very much.
Okay. Thank you, Dr. Chen Jin Hong, to give us an opening remark. And then let us introduce our first speaker tonight from Japan, Dr. Kazunari Ogulab, a director of Hachinohe Family Clinic. It's in a small city in Japan, and he runs a clinic in the city and also in the home care. And Dr. Ogulab today will give us the experiences how to cope with COVID-19 in Japan and how is the national policy now and how do they cope with the epidemic in the Hachinohe city. Let's introduce and let's welcome Dr. Ogulab. Hello, Dr. Ogulab, we cannot hear from you.
Okay. Okay. It was
Yeah,
muted.
no, it's okay.
Sorry. Okay. Now, thank you, Dr. Chen. It's a great honor to be here to talk to you today. And I would like to share my slide here. Can I share the... Okay, can you see the slide?
Please
Yes.
share it again because some of us cannot see. Please. Yeah.
Okay. Okay, I'm showing the first slide. Can you see?
Yeah, please continue.
Okay.
Yes.
Okay. So, okay, thank you. First, today I want to talk about dealing with COVID-19 in the community experience from Japan. But well, actually, it's just starting in Japan. We had two small waves of increase of patients in the last 6 months, but now what we call third wave is coming, and we are just starting to coping with the COVID-19 in local places. So let's start. First, I'd like to express my thanks to the Taiwanese people for sending us the protection, and Japanese people appreciate your kindness, and we are happy to help each other. And this is my pleasure to share our experience today. Let me introduce myself shortly. I'm a family physician and in Hachinohe. And besides, I have been working to promote a community-based integrated care system and a community symbiotic society that our government is trying to develop in our country. And I've been working as the head of NPOs in Hachinohe and nationwide. So Hachinohe is a core city in the northern part of Japan, Aomori Prefecture. Its population is 23,000, and area population, the medical area population is 350,000. And okay, so now I want to brief you on the current situation of Japan. infection of COVID. This is data from the Ministry of Health. And the number of the patients now, the total number of patients are 100,000. And now, as of today, we have PCR tests done, about 2.5 million. And this toll is about 1,800. These must be somewhere between the one in Taiwan and probably in the United States, I suppose. In our prefecture, though, we don't have that many patients. Actually, 2 weeks ago, we had only a total of less than 40 patients in the last 6 months. But now, in these 2 weeks, we had clusters in Hirosaki City and Hachinohe City. So the number is coming closer to 300. And they are the charts of the clusters. On the right side, we have a huge cluster map that happened in Hirosaki. It started from a nightclub and spread to the community, including 2 hospitals. And the number of patients total are now over 180. And on the right side up, we had the first small cluster, 7 people in a daycare service. And from that daycare service, it spread to a nursery home, a care house, yeah. And now the number is increasing here in the second cluster. So our governance policy has been changed the last 2 weeks. Actually, till October, we had this strict rule for patients. If you have a fever or cold symptom, you had to call the local healthcare center to ask for help. I mean, then the healthcare center would tell you where to go. If you're considered to be, to have the close contact with the patient, you were asked to go to the outpatient service for returnees and contact persons. But if you are not, and in most cases you are not, you are asked to go to your clinic, the local clinic, and even in that case, you had a very hard time seeking for a PCR or antigen test because it was restricted by law. I mean, you have to be very you have to be considered to be very likely to have the disease. Otherwise, it was hard to get the PCR test. But now, the government changed the policy, and now you don't have to call the local healthcare center anymore. You can call your home doctor or local clinics and hospitals seeking for care. And only when you don't have your home doctor or you don't know where to go, you can call the healthcare center and ask for help. But mostly we are getting the call from the patients, and we are doing the tests in the clinic and at home, in home care visit settings. And so this is how we're showing in the, it was the English subtitle was missing here, sorry. But this is the front page of my website. And here we are asking the patients to call in advance before coming if you have cold symptom or fever. And you can apply for online telemedicine from here. And when the patient arrives in the parking, they call us, and we are asking them to come into a separate space just for the suspected patients. And I'm seeing the patients with protection or by in-clinic telemedicine with this tablet like this. And when I decide to do the test, we're asking the patient to go back to the car in the parking. There's no car here, but just in front of the clinic, there's the parking. So we were asking them to stay there, and a nurse will bring the swab. And we are asking them to take the sample by themselves and get the swab and bring it back to the clinic and do the test. If they're not coming by car, then we're asking them to do it in this bathroom. And this is how we are doing here. We are doing the rapid antigen test. With that, we can check from the same sample, we can check influenza and COVID at the same time, and the result will be clear in 15 minutes. So we are preparing the same system in the Holiday Night Clinic. We run, the local doctors association is running. So we are now starting the system here too. And we find a COVID patient from here today. So these things we consider as the basis of this countermeasure should be the community-based integrated care system we have been developing in the local community, because we have to collaborate each other in this situation, and this collaboration must be the same thing we have been trying to promote in building this community-based integrated care system. Here in Hachinohe, we have the Connect 8 community team with which we are doing the monthly case conference. Now we are not doing it face-to-face, but we are doing it online. And also with ICT tool, we are sharing information and communicating on the internet. When you enter the tool, it's an SNS service, so you can see the patient you are in charge of. And also we have the application for a patient, so we can communicate with the chat with the patient and share the information in that SNS ICT tool. So we have been doing it for 5 years, and now it's commonly used in the community. And also we are promoting the collaboration of the professionals in the local places. Yes, I introduced it in Taiwan last year, and the analysis was published last month. And also we have been promoting the interprofessional collaboration, and these competency model we're promoting to be the core policy of the interprofessional collaboration. So based on these collaboration in the ICT network, we are trying to develop, establish an effective countermeasure for COVID spreading in the community. We've been using the ICT, and now we have telemedicine system connected with the ICT tool, and also we have online auscultation. So we are generally seeing the patient with telemedicine with the help of the nurse, but now we are doing the outpatient. We're seeing the outpatients as well, and home visits. We're replacing some visits by the telemedicine. And this is a device for online auscultation. It's called NextDate, This one is by the Japanese venture, but actually the device itself is produced in the plant in Taiwan. So COVID-19 countermeasure collaboration we are starting now in Hachinohe is like this. We are now having very small number of patients, but still, if the patients are hospitalized, we have to collaborate with the ER and the local government, and also if you are not over 65 and if you have the if you don't have the diseases like diabetes or hypertension and so on, you are from now on you are assigned to stay in a hotel or at home. Then you have to follow their health condition, and for that we are trying to use this ICT network and online telemedicine. So if you are staying in a hotel, we will observe the health condition with ICT and telemedicine. And if we need to send the patient to the hospital, we collaborate with the hospital. And this is a system for the hotel patients. We have this network system, SNS system, and online telemedicine, and also the auscultation. We are sharing it with the doctors in the hospital and the clinic to back up the nurses in the hotel. The nurses are staying in the hotel during the day, observing the patients by phone or online, and if they need help, they're calling us, the doctors in the clinic, and if we think that the patient should be transferred to the hospital, we are connecting to the hospital, and we can talk online and send the patient by ambulance. The follow-up condition check sheet, this is the governmental, provided by the government. We are trying to share it with ICT tool as well. And if you're asked to stay at home, we can do the same thing, but without the nurse. So we will use that
Hello, excuse me. Maybe the microphone is turned off. Dr. Ogulab, please.
Oh, excuse me, it was turned off. Okay. Can you hear me now?
Yeah.
Okay. It was accidentally closed. Sorry. From where shall I restart? Around
Just from
just from
yeah.
here.
Yeah.
Okay.
From
okay.
here.
Okay. Sorry. For home patients, we are preparing the same system, but without the nurse. So we are using the application for the patient and family, and if we need to share the information with doctors at home in the hospital, we are sharing it and referring them to the hospital by ambulance with the online consultation with the telemedicine. And also, we have a home visit nursing station backup system. This one is to help the nurses if they have the infection or close contact, and the nurse station have to close for 14 days, then the patients should be transferred to another nursing station, and the nursing station needs some help information. So we share the information with the SNS, and if you need more help, they can provide the help with online telemedicine like this. And also, we are so much afraid of the clusters in the nursery homes and housing for the elder people. So in the local doctors association, we prepare the medical certificate for nursery admission, uniform format for pandemic. So you don't have to bring the patient, elderly people to check unnecessary checkup or test to fulfill the certificate. And if we think that we need to check the COVID instead, the Doctors Association can issue the recommendation to have the test before admission. Okay, and so this is for the mental care. I can skip this one. And we share the information on the ICT, and also if we need to share the ACP information on ACP, we can do it on that SNS network as well. Okay, so this is what we are prepared. We have been preparing, and we are just starting to provide in this community. I hope everything will be, the things won't be worse. It's just started the spreading of the infection in Hachinohe and this prefecture, but we are trying to be ready, and we are trying to cope with it and to promote the infection control, and probably we will be busy in the coming 1 month, but I hope that things will be better in the next days. So here I came to the conclusion that COVID-19 countermeasures we are preparing and we are just starting should be built on interprofessional collaboration and ICT utilization we have been promoting the last 5 years or 10 years. And so this pandemic is a severe crisis to overcome, but I believe we can make our society better or updated by overcoming it. So we need to make this pandemic an opportunity to enhance the community-based integrated care system and the community symbiotic society we have been trying to develop. So that's the end of my presentation. Thank you for your attention. Thank you.
Thank you very much, Dr. Ogulab, to give us such a great speech about the current situation and the strategies in Hachinohe City. I think there must be a lot of questions here, and let me start first. And the first one is we are very curious about how to increase the perception and awareness in the community that to prevent from the spread, and what is the role of the family physicians to increase such an awareness in the community?
Thank you. Well, I think, and I'm experiencing here that the biggest damage people are having when they have clusters or infection or have some patients in their organization is that people sometimes insult those organizations or facilities or people having infected with COVID-19. So what we need to make sure is that as a family physician, we have to help people to understand the accurate knowledge about the disease and how we can prevent it, but the prevention cannot be perfect, so anyone can have it. So what we need to focus on is that try to be damaged less, less damage when we have some patients. So we can help those newspapers and people in the administration to have the better understanding of the disease and help them promote the knowledge among people.
Okay, thank you very much. And the panelists online, do you have any questions here, please? Dr. Pu, yeah.
Oh, yes, I have that was very inspiring. And just, you will see, this is, your system is such a big difference from the US system. And I'm very intrigued by your ICT network. And is that the case for entire Japan to have this? It looks like it's a uniform medical record. Is that right?
Well, we don't have the uniform medical record. It was just a format for admission for the nursery home, and well, this ICT network or connecting the information is not very common in Japan. Yeah.
And so you built that. Is that something you helped to design and create?
Yes, I designed it, and I'm trying to establish it here in Hachinohe, and
Yes.
trying to promote it nationwide.
Yeah. That's very impressive. And I just say also, the question about keeping people aware, and I think that each society is at a different part in where their preparedness needs to be, and it seems like for countries like Taiwan and Japan, you do need to engage media and the policy and government to help convey the awareness and seriousness of this pandemic. And I think family physicians play a huge role in the community through education and just more and more exposure. I think human beings are human beings. You can only do so much, and but I think that just continuing to with public communication and at a public health level, that's the kind of strategy you have to be engaging with the media and the government to help come together.
Okay, thank you, Dr. Pu. And how about Dr. Chen and Dr. Yu? Is there any questions about the presentation of Dr. Ogulab?
Thank you.
Dr. Ogulab, may I ask one question? How about your your doctor or the nurse get infected during this epidemic, during this pandemic time? Have anyone in your colleague in your clinic got the infection from the COVID-19?
Okay. Actually, we don't have anyone infected in my clinic or in the city, I guess. But there are some health professionals infected in the prefecture. When we had another cluster in the group home for people with dementia in the neighboring city, there were some nurses get infected. And also in some other places, we hear so many, especially when you're taking care of the patients in those designated hotels or nursery homes. Nurses are at a very high risk, so they are getting infections sometimes.
Okay,
Yeah.
thank you.
And Dr. Aguro, I have one more question. The hotels, was that in response to the pandemic to create these hotels specifically for pandemic? Yes. Okay.
Yes. Yeah. Well, we are choosing designating a hotel in place to place. In our prefecture, there were only 3 hotels assigned as a hotel to stay when you are infected. In each cities, I mean, in some places they have more. In Tokyo, there are many, yes, but still not enough.
Okay. I think we have similar hotels as for quarantines in Taiwan. I think we have these kind of measures. I have one question for Dr. Ogulab, because I'm very impressed that at the end of the conclusion, you made the conclude that the interprofessional collaboration is very important in countermeasures for COVID-19. And I'm interested in if there is any educational activities or any preparations for the interprofessional collaborations specifically for these coronavirus measures in Japan or in Hachinohe.
Well, we don't have this interprofessional collaboration integrated in our educational system yet, but in some schools for nurses or healthcare professionals, not in medical schools, started to have some lectures or courses about interprofessional cooperation, I heard. And there aren't any special training for this for this pandemic, but I've been doing some training sessions here in Hachinohe, and every time I'm using this interprofessional cooperation framework and trying to promote the notion and to utilize it to collaboration for the countermeasure for COVID-19.
So do you agree that the interprofessional collaborations for countermeasures are based on daily practice that's already built on these collaborations, and also because you have Connect 8 and these kind of ICT networks already set up, so there is easier for interprofessional collaborations. So maybe in the other cities or the other prefectures that don't have this kind of network before, it is more difficult to do the same thing that what you are doing in Hachinohe.
Yeah, thanks. I realized it when I do the telemedicine with the home care patients, because if I just see the patient for the first time and without the help of any other professionals around, I don't think I can be that confident in doing telemedicine. But we have the collaboration with the professionals, and we have been sharing the information, and so it was very comfortable based on that ICT. We are using the telemedicine, so everybody was feeling safe. We were comfortable.
Thank you.
Okay, thank you.
I would like to follow. Oh,
please.
Is that no? We have more time. You tell me what the time is. Yeah.
Yeah, okay. I think we're also very eager to hear from the presentation from Dr. Bu, and let's move to the second part. And Dr. Charles Harpu is the Medical Director of Care Continuum Programs at the Mass General Brigham Center for Population Health. And his job is also caring for the patient in the nursing homes. And he will give us some experiences and the presentation about how to cope with COVID-19 in a nursing home setting from the United States. Please welcome Dr. Joshua Tu.
Hi. Well, thank you. I'm very honored for the opportunity as well. Can you see my screen?
Yes.
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 Well, my focus will be on one kind of setting specific in the community, the nursing home setting. And I think we'll also touch on some themes that Dr. Ogura, Dr. Chen have also mentioned. And so this is a super spreader setting here in the United States. So my learning objectives after my brief talk is appreciate the impact of COVID-19 in our U.S. nursing home population and what were the factors that contributed to these results, and describe a few key lessons. And of course, I have a discussion on how maybe some lessons here could apply to your communities. So, devastating impact of COVID-19 in the U.S. nursing home population. And so it became very apparent this is where the pandemic entered into the United States. And back in February and March. This is where it's where the COVID entered into the U.S. And I think just appreciate the numbers here. We have Taiwan very low COVID, Japan little bit higher, and then the United States is on the other extreme. There are about 15,000 nursing homes in the United States, and it takes care of about 1.5 million people. It makes up about 0.5% of our population, but it accounted for over 40% of all the deaths related to COVID. And in certain states like my own, it was up to 65% of all COVID deaths. So this is a graph to see, like the red is the deaths related to COVID in nursing homes, and this green line is, all deaths. So just 0.5% of the U.S. population accounted for almost 2/3 of all the deaths. And it's just staggering. And so, like, why was that? And you'll see some themes here which reflects, the different health systems from Taiwan and Japan. I think that my title has this term care continuum. And what is the continuum of care? In the United States, it's kind of like it's all the different sites of services and where people can get care when they, for illness. And, primary care is in the community. But emergency and inpatient hospital ICUs. And then we have this whole area of after hospital care, recovery. And in the pandemic, the beginnings, the real focus was on the intensive care units, and that was where all the focus was in terms of trying to make sure our ICUs, because it's the fewest resources in our system here. Well, what it turned out was actually. I think we did okay, actually, in terms of overflowing in the ICUs. But what happened was it was totally exposed our nursing home. And so in Massachusetts, where I live in Boston, the government was overall praised for its pandemic response, which was very reactive. Okay, but it got it became very exposed, the lack of priority for the nursing home population. And so just a real quick primer on nursing homes. The nursing homes, it kind of serves two purposes in the United States. The nursing homes, many of the people who live in nursing homes, they're there for long-term care. That's where they live. And it's almost like each nursing home is two systems. So the long-term care nursing home, they live there, and it's funded by Medicaid, which is for people with low means. The other part is what we call short-term, short post-acute skilled nursing, and this is where many people in the United States, older people, get rehab after their hospitalization. Okay, and that's funded by Medicare. So this is just to kind of say the underlying policy where these nursing homes have to walk between two sides, where on one hand, they actually have to operate on a loss financially, and the other side, they can actually, do okay. And so it's a very tricky system. And we use, in the United States, we use the short-term nursing home a lot. And so we use this a lot. And this is the way it's connected to the medical system in America. But what happened was, every system is perfectly designed to get the results it gets. And the nursing home setting has been struggling for a long time. They're caring for more residents with dementia and increasing frailty. And of course, the people who live in nursing homes, they need the nursing home because they have heavy physical needs because of their frailty. So it requires very close contact by the staff. Well, unfortunately, the nursing home workers are some of the lowest wage earners in America with limited education. And they work at several facilities in order for them to, they often have to work at 2 or 3 different facilities. And also, it's not a place where a glamorous place to work. And so actually, it has some of the highest staff vacancy rates. So the staffing has always been low, the lowest in the nursing home. And so all of this created the perfect storm. And when when the nursing when COVID came in, and many staff got infected, and so there was no more staff, no more PPEs, and they had very limited access to testing. And this is what I had to live through. So this was the system that set up the perfect storm, and COVID is a silent disease, and didn't have symptoms. So anyway, I think that want to just kind of pivot towards just maybe 2 things which I'd like to share with you that I think may be helpful. I think that we learned that COVID exposed many weaknesses of our healthcare system in America. It's not integrated. It's very fragmented. And in order to fight this pandemic, you needed to bring together these three organizations: the nursing facility or the community center, the hospital and the health systems, and then the government organizations. And I'm going to just kind of share some, for each of these, how we, kind of use this framework to try and, respond to this in a reactive way. And so I think most of our experience here has been reactive to a crisis. We didn't have much proactive readiness. Okay, so first with the nursing facility itself, the nursing homes had to prepare for this pandemic, and the nursing homes had to, like with their staffing, train their staff, be taught infection control, be supplied with their equipment, and supported with clinical enhancements. Okay, and so I think that maybe I won't go through this, but I will just say that in terms of helping Taiwan, my main advice would be to plan and do drills, to prepare for drills. I think at this point, okay. And there's materials here to help understand, like, if COVID does enter into the facility, how you have to cohort patients, what's the protocols and the cohorting, because and these were kind of the experiences that we learned, is that basically you have to separate these patients safely. And we came up with some systems of 3 areas that we should prepare the nursing homes to have in advance. And these are for people who end up having COVID, those who you're not sure, but you're testing them for high risk, and then those who really don't have COVID. And so there are a lot of protocols that have been developed to help the staff exactly what to do for these patients. So I would say, like, we came up with a system of, first of all, very clearly defining the status of the patient in terms of clear colors, and then a cohorting strategy for where to place the patients, and some algorithms on helping the staff how to navigate these decisions. Okay, so that's at one nursing home level, and this is some evidence-based where this approach has been adopted in the country, around the world. Okay, red, yellow, green. The other thing I think I'd like to share with you is ACP. This is a system that I really like. It's called the Serious Illness Conversation Program. This is out of a very evidence-based approach. And this was studied very rigorously in terms of how to speak to patients, and it was designed in a randomized controlled trial, serious illness care, and the results were quite staggering, very positive. This was done a few years ago and was published, but the serious illness conversation is a standardized approach to have a ACP conversation with your patients. And the results in those who received this intervention versus those who did not had very powerful impact on in improving patients' anxiety and subsequent depression. And then in terms of just the quality of the conversations around ACP, in terms of quality of discussion around values and goals, understanding of their own disease, their feeling that they were able to express their preference for treatments and end-of-life planning, and that these conversations happened much early on before patients passed away. So this was a randomized controlled trial, and this has been adopted in our system and more across our country. And this is the format. It's really trying to understand the person's goals and preferences, their understanding, and using words like wish versus wishes and worries. It's just a very, they did a lot of research around the use of language for this conversation. And so there are references here, but I'm going to share with you kind of how the serious illness conversation was adopted for COVID, especially in the nursing home. So the setup is, we understand this is a difficult and scary time, and it's been made worse. And I wanted to speak because despite our best efforts, some of our staff residents tested positive for coronavirus. So these are all the different kind of scenarios to approach patients and set up the conversation. Like, why am I talking to you about this? If COVID is present in your facility, this is one recommended. If it's not, we are doing our best to prevent infection in our residents or in our community, but are preparing for the possibility that it may still come. And is it okay? I'm hoping how we can talk about how to provide the best care for you if you become sick. Is that okay? Okay, so like this is the kind of language. What have you heard about the coronavirus and how it might affect you? Just to understand where their understanding. And may I share with you my understanding of how coronavirus could affect your health. So as the family doctor, this is very powerful, okay? But it's actually very specific for coronavirus, okay? Most people in nursing homes who get the coronavirus actually get better, but if they do become sick, people who live in nursing homes actually don't survive very, very much, okay? And I like to make sure that we continue to provide you with the best care possible, and that includes talking about, whether or not to send you to the hospital if you become very sick. And can I ask some questions to help us think about this together? So each section is ended with another question to invite the further discussion, okay? And if the patient says, no, I don't want it, that's okay. This is something that can come back. And then, okay, so tell me, help me to understand some of the things that are most important to you right now, your life. What are you most worried about right now with the coronavirus? And if you become very sick due to this virus, how much would you be willing to go through to try and get better? Some people want anything, do everything to survive, even if it's not likely to work. Others would want to stay here with treatment focused on comfort, even if they may not survive. Okay, so this is a really nice flow. I feel it's been evidence-based to use for high-risk populations and specific COVID. Okay, so this is these are some references which you can look on this, but this in our health system, this is not across the country. Our health system, we have incorporated this this conversation into our documentation. So I should have shown some pictures on how we did this, but this has now become the universal way for us in our health system, in our hospitals, in our clinics to have this type of goals of care conversation. So I feel this is a very effective tool to advance practice of effective ACP. Okay. The other thing I'd like to say is, you know, in terms of preparedness, most of my experience has been, again, in response to a crisis that actually happened. You know, I think Taiwan, you're very fortunate you haven't had to do this. And, you know, in Japan, Dr. Gura, you had little small clusters and outbreaks. This was not the case. Our was on fire. Okay. So but it still comes down to this triangle of trying to create interprofessional collaboration, which I have to say in America never really was not very strong to begin with. Okay. The other thing I'd say maybe is just I think I'm going to just end with this as talking about interprofessional opportunity. This is called Project ECHO. It's called Extension of Community Healthcare Outcomes. And this is another very strong, powerful evidence-based intervention. And the story is very inspirational. This is a gastroenterologist from Boston who went and practiced in an academic in a rural part of the United States. And this was about 10, 12 years ago. He was a hepatologist and was trying to treat many of his patients with the new antivirals for hepatitis C. Okay, the problem is that in a rural place, so many patients could not access his expertise, and they were dying. And so he came up with a system, which is called ECHO, where he trained through teleplatform and empowered community doctors in the community to treat patients and care for patients with hepatitis C. And it was this system, and the results were amazing. With this platform so these patients, it wasn't patients, it was actually teaching clinicians, okay? The results were amazing. They actually had even better outcomes than the patients who came into his own clinic, okay? And the system is to democratize knowledge and get best practice care to underserved people all over the world. It uses these four core principles: amplification, sharing best practice, case-based learning, and then monitoring outcomes, okay? And it's a capacity building multiplier and just shows the difference between ECHO versus telemedicine. ECHO is, the ECHO clinic is supporting a community of ECHO learners who then will bring their knowledge to patients that they're taking care of. This is different than traditional telemedicine, which is the provider with the patient, but it's a multiplier. So it has the system of hub and spoke. The hub is the expert ECHO team, and they have a community of ECHO learning spokes, okay, and who are then really dealing with the patients. So it's not the traditional telemedicine, and it's not a webinar. It is consistent, systematic, educational telementoring. And when Dr. Ogura was sharing his experience, like in terms of, I think that this is kind of what you're doing, but this is like every week. And there's a very systematic approach towards this tele-mentoring. And we're starting to do this now across America. They're applying this with Echo Nursing Home. And the goals now is to create these hubs across the United States where the goal for nursing homes now is to prevent infection entry, helping the nursing homes prevent infection spread, promoting well-being of the patients, and promote staff well-being. And so we are just engaging across the country in bringing Echo to all nursing homes. And so in our setting in Massachusetts, I'm starting to be part of a team here that's going to be working with 35 nursing homes, and we are going to be engaged in this funded U.S. government-funded project, where we're going to be meeting with our nursing homes every week, learning together around cases with didactic sessions, and it's going to be an intensive 16-week engagement with the Echo team and the nursing home teams. Okay, and so this is a format of an Echo nursing home session, and where there is a brief teaching, and then a case-based discussion where we have a subject matter expert, and then a quality improvement conversation, and then wrap up. So it's I think that this is in many ways but this is a kind of I've become a real big fan of Echo in terms of being able to very efficiently scale and learn together. So anyway, I think I'm actually at the end of time. I think that maybe those are some of the things I'd like to just share with you, and maybe talk about other things during our open discussion. So any questions?
Oh, thank you for a wonderful speech from Dr. Charles Pu. And I think we can open to questions to the panelists. Please, is there any questions to Dr. Pu?
Yeah, I mean, I have to say, we had no experience with SARS, and there are other experience across the country where around the world where the nursing homes were very protected, but it is all tied into the structural system, policies, and the social characteristics of our healthcare system. And I think we have a lot to learn in the U.S. From a more integrated approach from Taiwan and Japan.
Yeah, actually, I have so many questions for Dr. Pu. Yeah, I think maybe I can mention the first one. That is, you mentioned the situation of nursing homes in the United States. I think it's a very good counterpart to the Taiwan, because we have smaller scales of nursing home or long-term care facilities, but also facing the staff is the staff will come and go frequently.
Yes.
And they have maybe lower staffs, and also the other issue is that some caregivers are from other countries because
Yes.
of language problems and barriers. So that I think we have some backgrounds, even the similar backgrounds of the perfect storm. So I think it's very, very important for us, especially for the nursing home and the long-term care facilities. Yeah, so, but how does it happen that the situation of nursing home get neglected in United States? Could you please give us more, for example, historical aspects of something about this?
Yeah. So, okay. The nursing home in America has emerged out of a very institutionalized approach. It's not like a home. Okay, nursing homes unfortunately do not have a great reputation. Like, no one wants to go to a nursing home in the United States. Okay. And in fact, more and more people are trying to use other ways to age through what we call assisted livings. But I think that the how did we get this? It's nursing homes have it is probably the lowest trust environment in the United States for where people receive care. Okay, and it's heavily regulated, the most heavily regulated healthcare setting, and it doesn't get enough money. Like, it's underfunded. It's underfunded, and it is and so I think that this was a real wake-up call for the whole for all of America to look at how it's thinking about aging. Okay, and it is tied to the bigger issue of how I think our society in America views aging, and so I don't know. It's not prioritized in America. Everything is really prioritized to the hospitals. Okay, and that came from policy way back in the 50s and 60s. Okay, and and that's why in America, most of our greatest advances are in our science, in our acute care. But this is a big struggle in America now, where the aging has happened so much that our approach towards very high-tech, high acuity medicine is no longer able to really work for an aging population that have multiple complex conditions and need more of a team-based approach, interprofessional team, and even actually a community, a societal approach. And so it is very tied into this. It's all interconnected. I don't know. It's a very deep problem. It's a very deep problem, and it's interesting. I was interested to hear that in Taiwan that you recognize some of the similar elements for a perfect storm. I didn't expect that.
To supplement each other. I mean, if we have the good relationship with the patient and the family, and if we have trust between the interprofessional collaboration, and then we don't have to be afraid of refraining from visiting the homes or nursing homes and replacing the visit by telemedicine. Because as I told you before, in that situation, we are not feeling unsafe, or the patients were so happy to be visited by online telemedicine, because they're also afraid of getting infected. And also, we are afraid of getting infected or spreading the infection. And this can just strengthen our mutual trust. And we didn't lose anything by replacing the visit by telemedicine during that period. So the important thing is that we have to first establish the relationship with the patient and the family, and the trust between the professionals collaborating together. If we can succeed in making it in a daily basis, we can use the telemedicine very effectively during this pandemic, I think.
Thank you. How the patient, how many patients you keep with telemedicine and home care to keep in the community, not sent to the hospital?
Okay, yes, that one we are trying to analyze now. We have just started to analyze the outcome basis. And we will get the results in the coming months. But we are trying to, of course, one of the goals we are trying to achieve is to prevent the patients at home not to be hospitalized. And to do that, we are trying to react as much as soon as possible when they have some, symptom or a fever or some sign for a serious disease or infection. And that ICT and telemedicine helps us a lot in doing so. Today as well, I was seeing the patient on the outpatient basis, and one of the home patients got high fever, and the nurse visited, and I just asked them to do the telemedicine and online auscultation, and we managed to respond very quickly, and we started treatment. So that, I think, prevented them to prevent the patient to be hospitalized. So in this type of collaboration and use of telemedicine ICT, that can help prevent the patients to be hospitalized when they want to stay at home. So probably, I hope that the outcome will be the one we were trying to achieve. Thank you.
Yeah. Thank you.
I mean, I'll share about the home. We do have some data looking at the success of home-based care and keeping them out of the hospital. So in Massachusetts, we have a program which is government supported to help frail people stay in their home who almost meet nursing home criteria. Like, in order to qualify for this help at home with an aid, you have to have 2 activities of daily living impairment. Okay, so these are quite frail people, and the results for COVID compared to the nursing home was night and day. The mortality for this group who were cared for at home by a consistent caregiver was like accounted for less than like 1.5% of all the deaths compared to the 65%. And they're almost similar type of patient phenotype. Okay, and then the other group that we did a lot of work with proactively is we have a population that consists about 5% of our older population who are the very high risk patients, who we would say are like the top 5% in terms of how much they use hospitals, and once COVID came, they wouldn't go to the clinics anymore or hospitals, and so we did all these visits using lists who are the list of your patients that you need to be calling? And we didn't do fancy virtual visits, just using the telephone. Okay, like this was most of the work we did. Again, we saw quintupling of having ACP conversations that were documented during this time, because that was part of this whole protocol. And again, the results are going to be published as well from our experience with this, but it was actually very successful. There was not much change in the utilization and hospitalization of these patients. So, but then this was not so much with a home-based home-based primary care. We don't have a home-based primary care program, here in Boston, but this was just intensive outreach using, telephone, virtual visits when we can, to be in touch with these patients on a very proactive way.
And
Okay, thank you.
and I have one question that to Dr. Pu and also to Dr. Ogulab, that I mentioned that in the Dr. Pu's presentation, you classify your patients into 5 categories, and the space design is very interesting. That you keep the single and private room for the suspected patient. That means in your blue, orange, and the gold patients, that you try to decrease the contact and spread for even the suspected patients.
Correct.
Yeah.
Correct.
Yeah. To
Absolutely.
decrease in the plaqueless spread. That would be very, very
Right.
important step. And
Very important.
yeah, and that question goes to the Dr. Ogulab. In your flow chart, that if the patient got suspected, I didn't see any the way that will they go to their own homes, or will they go to the designated hotel too? And because we cannot sure that he or she is confirmed or not. In this quite ambiguous period, where will they go? Will they go to their own homes? Will they go to the hotel or something else? Could you please share with us? Because the space design, maybe the design in the nursing homes, in Dr. Pu's nursing homes, will be also very important to the community design too. Yeah.
Okay. The patient flow I showed you was the flow for the patients tested positive. Yeah.
Yeah.
And we have the infection disease control law, and according to the law, if you have tested positive or you're confirmed patient, you have to be hospitalized, or from this month you can choose if you don't have underlying health condition, or you're under 65 years old, you can choose to stay in a designated hotel or at home. But if you are not tested positive, but you're suspected and you have contact with some patients, positive patients, you are asked to stay at home, your home.
Yeah.
But it's not compulsory, it has no background by law.
Yeah, but according to the experiences by Dr. Pu, it might be a very, very important step. Yeah.
In the nursing home, it's because it's a group living.
Yeah.
Okay, it has to be very strict. And I agree, in the community, home should be fine. Home should be fine. The COVID positive patient, the red patient, in many ways is very easy. It's very clear. The most tricky, the most dangerous, I think, is the orange, which is the suspect, or the orange is very tricky, but even more is what we call the blue, is the exposed patient. the exposed patient or potentially exposed, they're asymptomatic. They are asymptomatic. And the only way you can resolve them is through time. Like you can only quarantine them. But a suspect patient who develops symptoms, you can actually quickly test them. And it's a very smooth protocol that you can do. But yeah, it's I think in a nursing home, where they are placed is very important. Like we really feel they need to be in a single room. In a nursing home setting or in a group setting, any orange or blue patient need to be in a separate room.
Yeah.
They need to have a single room.
Yeah. And maybe for the in order to prevent a cluster, maybe the daycare centers and also nursing homes or the community centers for the elderly, it must be quite with under a strict control or even shut down in the pandemic or epidemic in the community. Yeah.
Right.
Yeah.
And I'll just say one other thing is another thing that helped us control this was what we call very intensive surveillance testing.
How frequently, please? How frequent?
Oh, okay. So it was, I think, so it was every week.
Every week, okay.
All of the staff needed to be tested, okay?
Yeah.
This is in a nursing home. Okay, so all the staff needed to be tested every single week. And only if your staff was 0 for 2 consecutive weeks could you go to every other week testing. I think maybe once a month testing or something like that. Okay, so like the surveillance testing is because we didn't do good contact tracing, but I think surveillance testing is something that ended up being very helpful for us. Yeah.
I have one question, Dr. Pu. During that surveillance period, where those staff are staying? Are they staying at home or?
Yes, they're staying at home. They are staying at home.
Because here in Japan, they're afraid of giving the infection to the family. So in some facilities which experience the cluster, those staff are staying in their, even in their cars, and some facilities are providing the prefabric housing for them for the period or something like that. So how are they doing it in the States? Are they all going back home?
Yeah, they are going back home, and I think that they are basically offering testing for family members too, to kind of help with that. Okay, and so I mean the nursing home staff, because they were hit so hard, I think that they have a very high awareness of this and ended up practicing very safe care. And they very quickly stopped going to other nursing homes and things like that, but they ended up, offering surveillance testing for their families at home.
Okay, also for the family.
Yeah.
Okay.
I had a question for Dr. Ogura.
Yes.
The hotels, can I ask, what was the process for you to create these hotels, and how did you engage the government to do this? I'm just curious how you did this.
Assigning a hotel for a patient is a government policy from the beginning. They're already doing it in Tokyo and everywhere. But using these ICT and online telemedicine is my idea, and we were just starting it here in Japan. Yeah.
So there was already policy to use hotels for health purposes at times, right?
Yes.
Okay, I see.
Okay, any questions from Dr. Yu or Dr. Chen? Okay. Okay. Now I think we have well, actually, I learned a lot from the presentation from Dr. Pu and Dr. Ogulab, especially that I think for the in order to prevent the spread in the community, how to block the spread trajectory, or how to design the space in the community to prevent from the spread is very, very important. Maybe we can think every community is like a small country that we have a relatively strict border epidemic control, and also with the frequent surveillance. But now the challenge is that in the super age society, how to keep this isolated elderly with the daily activities, and how to decrease and prevent the frailty or any other complications at home or in their residential area. I think that will be another questions, another challenges we must face. Maybe Dr. Yu or Dr. Chen could share some experience or thinking about that. Yeah.
But I really experienced in Xinjiang, because we don't have the experience with COVID-19, but in Taiwan, now we have no new case in Taiwan. So just we keep the social distance and mask wearing in everyday life, and also we encourage the old people in our community. We live together, but we keep the social distances and obey the law of wearing mask. Another, we keep washing hands very frequently. So as everyday life, to incorporate this kind of measure, how to prevent the prevention. And at another time, they keep the daily activity. So make them, from the psychology, they can feel very, they engage in this kind of daily activity to make their body more healthy, and make their the mind more healthy, and at the same time to increase their defense mechanism. So in Xinjiang, we do this kind of work as in Suyan, as you know, have you visit last week in Suyan. So I think it's, but I feel that if any local transmission occur in Taiwan, maybe we will change our strategy to make our people, especially the old people in our community, and how to do at the same time not only prevent themselves, protect themselves, but also through the community work, we working together. Like Dr. Ogulab say, is a symbiotic community. Maybe it's a goal of us to achieve that kind through the interprofessional relationship, and also in the not only professional, but doctor and other people, we working together to make our community more safe. I think it's our goal. And tonight, very happy that we have many experience from Dr. Yu and Dr. Ogulab in Japan. It's very, very helpful for us to keep our community safe, especially for these old people. Thank you very much.
Okay, thank you, Dr. Chen. Yeah, please. Then now, please, Dr. Yu to give us a closing remark. Dr. Yu, please.
Okay, I think Taiwan is a very lucky country, a very small island with only 23 million people living here. But because it's an island, so it's easier to make the border control to avoid the spreading of coronavirus in Taiwan. But I think we still don't have enough proactive measures in our community to ensure that if there's any outbreak in the community, what we will respond to that. So, like Dr. Pu said, very intensive surveillance of a limited area, I think it's one of the important measures that we can do. And like what we saw in Dr. Ogulab's slides, they have influenza and coronavirus, the rapid test, because we don't have that kind of test in our clinic or in our, I think in most of the primary care settings, we don't have the rapid test. So I hope our government can be more proactively to enforce and to strengthen our facilities in the primary care system, that we can face, that we can make our fellows and the other primary care physicians be more confident in facing the coming outbreak if it happens. But on the other hand, we know, as we saw on the news, that many elderlies, whether in Europe, in the United States, or in Japan, because of the lockdown, because of they cannot go out, so develop many problems because of frailty, sarcopenia, and malnutrition. So I think not only the healthcare system, but also our social support or social security system will have to be more proactively to make the delivery systems of life supplying network, and to make sure that every elderly or every people living alone, when they face the lockdown, what happens to them. And because Taiwanese people like to watch TV very much, they family, so most of the homes take the proactive activities by televisions, and that is why our government, they are making public health news or public health commercial news that on the television to make sure that all the citizens, they can understand and they can react to the outbreak, or to avoid the frailties and to do exercise at home. I think this is the next step for our healthcare system to be prepared for any lockdowns in the coming future. I'm very happy that we have, because both Doctors Pu and Dr. Ogulab are very good friends of us, and we have been seeing each other in many cases. So we are looking forward that we can work together and to finish this pandemic, and then we can see each other again and have more communications in the future. Thank you.
Okay, thank you, Dr. Yu. And I would like to invite, because we have two wonderful and interesting speech from Dr. Pu and Dr. Ogulab, and now I want to invite Dr. Pu to give us a short closing, please.
Okay, well, again, just it's been such a great experience. And, you know, I think that nobody knows the answer. Nobody really knows the answer. What I learned here, you know, may not be so applicable to each of your settings. And I just have to say that, this is where kind of leadership comes, where there's no book you can go to and say this is the way to do it. Maybe we have more information now, but I think all of us in our settings are the experts. And even more important is the people you can gather in these interprofessional teams to figure this out. So, I think that the issue you just mentioned, Dr. Yu, about how do we go to the next step of trying to bring more well-being to our communities. We can lead by bringing these groups together to solve these problems. And, and I think and that's what we're all trying to do in our ecosystems. And to leverage, you have a lot of strengths where all of you are, and and we are a big community to try to learn and support each other. I hope you never have to get to where I had to go through, and still going through. And I hope that your work with your interprofessional teams in your communities that you bring together, that you can test different ideas, and I've just learned that the people actually know a lot of the answers. Like, they have the great ideas from your teams, and to just keep on doing that, but it takes the leadership to bring these people together so that they can effectively channel their ideas. So yeah, we have a lot to learn from you, and I hope that we can hear how you can help us figure out how to more safely open up, because we're still struggling.
Thank you, Dr. Pu, and hope that is getting better and better. And now we invite Dr. Ogulab to give us a short talk. Finally, please.
Okay, thank you. I've learned a lot from the experience of Dr. Pu and discussion with doctors in Taiwan. We are now getting into the more serious situation here in the local place in the northern part. We are the safest area in the country until now, but the fire is spreading here in the end. So what we are trying to do is, just like Dr. Pu said, we are trying to promote the people in the community to have leadership in their professions and in their settings, and to combine these efforts and leaderships, we can make that community better, direct to the better direction. So I think what we are trying to do is what we have been trying to do in the past, and we just keep on going. And nobody knows the answer, but we can we can keep on exchanging information, and we can keep on help each other, I hope, and so that we can be better off in the coming months or year, hopefully months, in each of the situations. And I think having these conversations with the people trying to do their best in their own settings is a good mental care for us as well. So I hope this kind of conversation can be available for in many situations and places. I will try to do it here in Japan, also in Japan. So I've learned a lot today, and I really thank you for preparing for everything for tonight. Thank you.
Thank you, Dr. Ogulab. We are in the different countries. We face different settings and situations, but we think it's really a big challenge for us. But it's also a chance for us to how to build, empower, enhance the power of our community. Not in a geographical one, but how in our citizens, how in our peoples in Taiwan, in United States, and also in Japan. How do we build this kind of community, mutual respect, mutual assistance, like that, for a symbiotic community? I think is also our challenge, and the way maybe is the only way to beat up this pandemic. Yeah. And tonight we have a very, very intellectual and interesting night from 3 countries. And now it's time to the end of this webinar. And next month, in December, we also will have a webinar. It's just in Taiwan. We will invite Dr. Chen Jin Hong to give us a talk about during these 6 webinars from May to November, and how do we have a conclusion that facing the challenge in Taiwan, in the community, what is the next step for us? So please, and if you have any, for example, any interest, maybe we can send the message and the link also to Dr. Pu and Dr. Ogulab. And thank you so much for your presentation and sharing tonight. See you next time. Hope we can see each other in telemedicine way,
Yes.
and also in person. And yeah, okay. See you. Yeah, bye.
Have a nice weekend.
Yeah, have a nice weekend. Bye.
Thank you.
Thank you.